Thank you very much for this opportunity to talk to you about the comorbidity burden in men with prostate cancer. I'm Phil Cornford. I am an associate professor at the University of Liverpool and vice chairman of the EAU prostate cancer panel. You can see here that I have worked with some of the companies involved in this field. And this is my declaration slide. So, what are we going to talk about? For the next 20 minutes, we're going to discuss the different comorbidities in men with prostate cancer. How many do they have? And how does this affect non-prostate cancer outcome? And perhaps prostate cancer outcome as well. Who needs more assessment before making a decision about treatment? And then for the last section, I'm going to talk about the cardiovascular risk. Now, I don't suppose anybody in this audience needs reminding that prostate cancer is increasingly common with age. Here we have a graph from Asia and Australasia on one side and a graph from the UK on the other side, showing that the incidence of prostate cancer increases with age. In addition, you can see at the bottom that the incidence of prostate cancer increases with each age group and is up to 1 in 14 for men in their 70s. This is American data from the SEER database, and you can see that the median age at diagnosis in America is 66, but the median age at death is 80. So this remains a disease of men as they get older. And the trouble with getting older is that you get other things go wrong too. You can see here, the dotted line shows the risk for people between 60 and 64. And of those people, nearly 2/3 of them have at least one other disorder. And as we get older, we get an increasing collection of disorders. So prostate cancer is rarely treated alone and is often treated in the background of other medical conditions. And it's that we're going to talk about today. And I'm going to start with assessing frailty, or at least how that comorbidity might be affecting people. Now, this first slide tells us something about those people who elect to have screening. Traditionally, urologists have tended to overestimate the life expectancy of people with metastatic disease and underestimate the life expectancy of people who have localized or regional cancer normally detected by PSA screening. In graph A, you can see the dotted red line shows the average male population. And the green line looks at the non-cancer deaths in those people diagnosed with colorectal malignancy. And it very much mirrors the average life expectancy for American men. For those people with lung cancer, even if they didn't die of lung cancer, they're more likely to die of something else than the average man. But those with prostate cancer, this isn't true. If prostate cancer doesn't catch up with them, they live longer than the average man. So if we split that out in graph B, you can see that those people with metastatic disease die more quickly of other non-prostate cancer causes than the average American man. But those people with localized disease live longer. And this suggests that people who elect to undergo PSA screening are more interested in their health and generally live a better, more health conscious life. And so their life expectancy is greater than the average. And that's worth bearing in mind. Now, when we come to assess prostate cancer and likely life expectancy, particularly as men get older and they have more comorbidities, it's difficult to predict accurately exactly whether they'll live another 10 years. But the EAU has worked with SIOG in order to adopt this G8 screening tool. A full geriatric assessment is beyond the capacity of urologists in practice. But this fairly simple screening tool will allow you to understand whether or not a patient needs further specialist assessment. And you can see as listed here, a lot of this is to do with weight loss, mobility, psychological or dementia. The body mass index, interestingly, is just about weight loss rather than being overweight. That doesn't seem to be a risk in this population, but clearly taking more than 3 drugs per day might be a risk. And then how they feel, how they are compared with people they know. And age is the final thing. It gives you a maximum score of 17. And fit people will get 15, 16 or 17. For those people scoring less than that are likely to need some form of assessment. The other thing to think about in conjunction with this is the mini-cog. I'm sure that you will all remember doing mini-cogs during your career, but it involves a simple 3-word registration using one of these lists as seen below. They're asked to repeat those 3 words to you. They're then asked to draw a clock face with the time set at 11:10, and then to recall the 3 words. And that will give them a score like this. And it is a proven way of detecting people with cognitive impairment, and which will clearly make a difference to how people are treated if they've been diagnosed with prostate cancer. So this graph, those of you who've read the EAU guidelines will recognize, and it shows that if your mini-cog is normal and your screening G8 is normal, i.e. greater than 14, no further evaluation is required. These people are deemed as fit and should be treated in the same way as younger individuals. For people with a G8 score of 14 or less, they might need more assessment. It depends a little bit upon how much of a problem they're having. For those people with an abnormality of just one activity of daily living, or just a small weight loss, they're considered to be vulnerable in group 2. And those people with more comorbidities, with more severe grade, are considered to be frail. So the fit patients, as we've already said, are just treated in the standard manner, regardless of their age. But the vulnerable patients will need assessment and potentially can be moved into the fit group and have standard treatment if geriatric assessment and intervention allows. And the frail group are probably not appropriate for radical curative treatment. The other way of assessing life expectancy by age is looking at gait speed. Gait speed is a fairly standard measurement and has been proved to be reliable. From a standing start, men are asked to walk 6 meters and timed. For those people who take 15 seconds to walk the 6 meters, they have a gait speed of 0.4 meters per second, whereas those people who take 4 seconds have a gait speed of 1.5 meters per second, as in here. So if we look at people who are age 75, if you have a gait speed of 1.5 meters per second, you have over a 90% chance of being alive in 10 years. Whereas if you have a gait speed of 0.4, then you only have a 1 in 5 chance of being alive in 10 years. And clearly that would alter how your prostate cancer is treated. Now, life expectancy is important at 2 ends of the spectrum, but this is data related to those people presenting with metastatic disease. So it's clear that you shouldn't be offered curative treatment unless you're going to live long enough to gain a benefit from it. But if you've got metastatic disease, then you probably benefit from combination treatment. Of course, the question is, who would benefit? Most of the studies used ECOG performance status, but you might use a more complex system as shown here. I think that the obvious thing to do is, can they do their own shopping? If you can do your own shopping, you are ECOG status 1, and on that basis, you are fit enough for combination treatment. So, we talked a little bit about how we might assess comorbidity and why comorbidity is important, but what effect does it have? This is the Charleston Comorbidity Index. This is the original version, and it has been updated since, but I'm going to show this one because it was the one used in the next study that I'm going to show you. And you can see here that you can have a number of different issues which will give you a score. So a fit person with no comorbidity has a comorbidity index of 0, and you can add these comorbidities together to get increasing comorbidity. And this data has used that by splitting those patients who are fit in the top row from those people with a comorbidity index of 1 or more. And you can see that the red bar is deaths from prostate cancer and the blue bar is deaths from other diseases. Now this is a group of men with high-risk prostate cancer. There were nearly 4,000 men included, and these people had either a PSA of over 20 at treatment, a Gleason score of 8 or more, or a T3A disease or more. And they were treated with radical surgery and lymph node dissection, and then followed, but they didn't have other treatment. And we can see here that as you get older, you are increasingly more likely to die of another disease than your prostate cancer. And if you have just one comorbidity, then you are increasingly likely to die of another cause. Now, up until now, we have been worried about over-treating patients with insignificant disease, but these men don't have insignificant disease. Of course, the question is, well, maybe they just had an elevated PSA, so maybe just one risk factor isn't so bad. What happens if they have 2 or more of the 3 possible risk factors? And for young patients, the risk factors are what's driving their cause of death. But as we get older, the risk factors become increasingly important, and it's the risk factor and the other comorbidity which is the predominant cause of death. I think we need to remember that. I also found this study based on Canadian data, and it shows overall survival in men who didn't have any other treatment. The blue line are men who underwent surgery, and the yellow line are men who underwent radiotherapy. And superimposed on it are little black crosses, which are events, which are deaths. You can see there were over 9,000 men included in this study. And these men all died of something else. Perhaps the first thing to say, of course, is that surgeons are really good at selecting out people who will do well. Because look how much better the surgical group did than the radiotherapy group. This isn't better because they did better from their prostate cancer. This is better because they didn't die of other comorbidity. And it makes it very clear why there are issues when we compare databases looking at surgery versus radiotherapy. But from this data was produced this nomogram. And you can see here, this is another way of predicting 10-year life expectancy for people who underwent surgery and radiotherapy. So, cardiovascular disease. Why we're going to concentrate on cardiovascular disease. So this is UK data, and this is cause of death for men in the UK. And you can see that cardiovascular disease is 29% of all deaths. Cancer is 32%, and the other causes are listed there. Interestingly, diabetes by itself, just 1%. So it is the most common cause, second most common cause of death in men generally. It is also the second most common cause of death in men with prostate cancer, based upon the studies that are on your slide. And for men with prostate cancer and a pre-existing cardiovascular disease, based upon this data from Denmark, you can see that they have an increased risk of death. It's stronger for those people who had a stroke than those people who had cardiovascular disease, but it's significant for both groups. So, cardiovascular risk and prevalence in men with prostate cancer. This is the age of diagnosis in the UK, and this is the long list of comorbidities and cardiovascular comorbidities in particular, which we see in the UK. And you can see that nearly half have, just over half have high-risk disease, a third have intermediate risk disease, and only a minority, a tiny number, actually are low risk for further cardiac events. We look here, 17% in this study had coronary artery disease. And here we can see the risk based upon the Framingham index. And these people in the high risk group have a 20% chance of a further cardiovascular event at 10 years, and the intermediate group somewhere between 10 and 20%. And that's why these people are so much at increased risk of cardiac issues going forward. So when we think about cardiovascular risk, we have to remember that the highest risk is in those with a pre-existing vascular disease, particularly stroke and TIA, but myocardial infarction, bypass grafting, stenting, angina, ischemic heart disease, peripheral vascular disease, and diabetes are all increased risk. And I don't know about you, but many of the men that turn up in clinic to see me have some of these comorbidities. Just want to draw your attention to this data on previous MI plus or minus diabetes. So the top graph, this line here, is those patients who don't have diabetes and didn't have an MI. And you can see at 20 years, most of them are still alive. If you have an MI or have diabetes, these two curves nearly overlap. And if you have diabetes and an MI, then less than half of you will be alive 10 years later. So diabetes and myocardial infarction are cumulative, and we can see this with other data. So here we can see if you had exercise, if you had treatment, things improve. But if you have hypertension, if you have abdominal obesity, if you have diabetes, if you're a cigarette smoker, these things all make things worse. We all know that, really. And the risks and benefits are additive. Now, we can assess risks for an individual patient using the Framingham score, which is based upon age, gender, the ratio of total cholesterol and high density lipids, whether they smoke, whether they have diabetes, their blood pressure, and whether they're having any treatment for blood pressure. And that will give you a calculated risk of future events. In the UK, we use a related Q-RIS2 assessment, but it's very much designed to do the same thing and is based on many of the same principles. So what can we do to modify risk? Well, for all men who come and see us in clinic, stopping smoking is more likely to make a difference to their longevity than treating their prostate cancer. Diet, weight, looking at the fat content of their diet, the salt content, the total number of calories, and decreasing the amount of alcohol will all help. Increasing physical activity and maintaining blood pressure within a target, as shown, is proven to be effective. For those people who've had a previous myocardial infarction or one of these other risks, then they will need secondary prevention in order to try and prevent them having an attack, a further attack. And that might include atorvastatin. It certainly is likely to include a statin at A level, and might also include aspirin, beta blockers, ACE inhibitors. And these patients are going to need support of a cardiologist. For those people at increased risk, including the groups you've seen there before us, then they have, if they have over a 10% risk of cardiac event in the next 10 years, then they probably should be started on a statin. So now we'll deal with any questions.